So I really want to talk about lipids and why we should care about lipids and the challenges that we have in primary care in actually implementing lipid management. And Professor Fish has already highlighted at the start of this lipid symposium that actually if we follow patients through the correct pathway and a two-stepped approach, we can actually treat most people with statins and get them to target, with only a small number, 14%, maybe requiring some of the newer therapies. So for primary care, there are a few controversies. So when NICE came out with their new guidelines in 2014, there were 96 recommendations in that guideline pathway. And I can tell you now, most people in primary care won't have looked at them, and I suspect most people in secondary care probably haven't looked at them as well. But I'm going to highlight some of the things that I thought were important for primary care. So QRISK is QRISK-2 is the tool that's most commonly used. We do have QRISK-3 now, but it's not implemented, it's not mainstream, and it's not embedded into EMIS. What NICE has said for primary prevention is that we should be offering statins to everyone with a QRISK score of 2 or 3 above 10%. So that's a big change. So it was previously 20%, and so we dropped it to 10%. So what does that mean? It means that in England, 4.5 million people should be treated with a statin. 80% of men over 50 will require a statin, or 55% of women over 60 will require a statin for primary prevention. The next big controversy is that NICE said we should offer statins to all people over 85. That obviously needs some clinical context. And if we contrast that to the American guidelines, they actively discourage statin initiation for primary prevention for people over 75. And that was 2016. The next thing is that statins should be for everyone with CKD, and CKD was defined as an eGFR less than 60 or an ACR greater than 3. And then NICE said for secondary prevention, 80 milligrams is a recommended dose. And actually, when we drill into the data, when we look at composite study data for outcomes that high dose statin to mid dose statin, there's very little difference. But when you look at individual pool data, you might see some benefits at the higher level. And I think NICE made their decision on 80 milligrams based on economic modeling. We've already heard now that 1 millimole reduction in LDL can equate to a 23-24% relative risk reduction in cardiovascular events. So from an economic modeling point of view, I think NICE made that decision on the 80 milligrams. I think in the acute setting, I think high dose statins can be very beneficial, and in part from their effect on LDL reduction, but possibly some other effects that statins have, which we call pleiotropic effects. So what's the target? So NICE recommended for us in primary care that we should aim for a 40% reduction in non-HDL cholesterol for both primary and secondary prevention. And so I think it went for non-HDL because it's really hard to measure LDL in labs. It's expensive, time consuming. And so labs now will measure LDL based on an aggregate of total cholesterol minus HDL minus percentage of triglycerides. And most people don't realize that non-HDL isn't the same as LDL. Non-HDL is total cholesterol minus HDL. And when we look at the trial data, most trials look at LDL with the assumption that 40% reduction meant non-HDL fell by at least the same amount. And a more than 40% reduction in LDL equaled a low rate of cardiovascular events by over 2 to 6 years. So why are we missing the targets in primary care? And so we've touched a little bit on this, but a big one is non-adherence. And when we look at data, 30 to 40% of patients sometimes forget to take the tablets. And if we ask our patients, do you ever miss your tablets? The numbers say, oh no, I never miss the tablets. So a more useful way to phrase that is, in the past 3 months, how many days might you have missed a tablet? And you'll often get a more accurate answer. In secondary prevention, 40% stopped and then 72% restarted, and that was similar for primary prevention as well. The real stoppers, these are the patients that stop and are much less likely to restart. And this is influenced by belief, particularly media, and clinician attitude and belief. And Marge really highlighted the importance of having time for these patients to explain what we want to achieve, how we want to achieve it, and listen to the patient and explain. So when we listen to our patients, they tell us that statins cause side effects. But when we look at the trials tell us statins don't really cause side effects. So there's a bit of a disparity there. And obviously, we've got medication adverse events, which are both true and nocebo. In primary care, we're very driven by QOF. And up until recently, the QOF target for secondary prevention was a cholesterol less than 5. That was great. For me, I could look at my labs. If it was under 5, tick. I've done my job. Now we have to look, we have to calculate a 40% reduction in non-HDL. So that involves going in, looking, making the calculation. So we often have little crib sheets to see what does that, so we can quickly do it. But when you've got a big list of labs, it's hard to do, and so it can slip. So these are some of the problems we have in primary care. So what about safety of statins? So we had this question earlier on. And so when we look at some of the trial data, long-term follow-up from the heart protection study, which is a 5-year study, plus an additional 6 years of follow-up, that there were no change in non-vascular outcomes. And so there was no benefit, no harm signals seen. There was a paper in the Annals of Rheumatology about osteoporosis, showing that high-dose statins may have a greater chance of having osteoporosis. Now, this was a cohort study, so we can't prove causation, and we may hear a little bit more about that in the future. But so the latest I've heard from Simon is that statins aren't associated with any fracture risk. So it's something that may go away, but it's out there, and patients often ask about it. We've had the question about cancer. Well, the heart protection study showed no increased risk of cancer. And in terms of memory, there's no clear increased risk, and that was confirmed by the US Preventive Task Force in 2016. With regards to the diabetes, patients will come in and say, well, that increased risk of diabetes. And Vinita's already told us, if you don't have any baseline risk for diabetes, then you don't have any additional increased risk. If you have risk factors for diabetes, then we've seen in the primary care data that over a 4-year period, 1 in 250 may go on to develop diabetes, but their risk from having a pre-diabetic state or risk factors is far greater for cardiovascular than going on a statin. So we really want, it's just about that education support for the patient. That if you're eligible, you should take, the statin's useful to you. So what's new? So I don't know if everyone saw the BMJ last week. So there's a really good article last week which said the benefits are modest and depend on the baseline risk. So there are 200 million people around the world taking a statin. A meta-analysis of 21 randomized trials for primary and secondary prevention showed only a modest absolute risk reduction. So 0.8% for all-cause mortality, 1.3% for MI risk reduction, and 0.4% for stroke. And if we contrast that to the relative risk reduction, which we hear about, we can see that all-cause mortality, 9% reduction, MI reduction, 29%, and stroke, 14%. So there's a difference. And in this analysis, 77 study participants need to take a statin for just under 4.5 years to prevent 1 MI. And so what that really means is that a lot of people will take the statin who wouldn't have had an event anyway. So patients should be told about the potential risk reduction, and it depends on your baseline risk. We've dropped the baseline risk to 10%, therefore the benefit's going to be smaller. If the baseline risk is higher, the benefit's greater. And as the author stated in this article, reporting relative risk reduction without a baseline risk is the first sin against transparent reporting. I think we just have to have that shared decision approach to our patients. What about statins commonly causing muscle pain and stiffness? So also last week in the BMJ, just reported on that study from the British Heart Foundation funded in December last year, that statins don't commonly cause muscle pain and stiffness. And this was a really small study in primary care, looking at 200 people across 50 GP surgeries in England and Wales, where 69 were prescribed a statin within the past 3 years who had considered stopping or had stopped due to muscle symptoms. And these patients were divided into 6 treatment periods, each for 2 months, and they were blindly randomized to either having a statin or placebo, and they wouldn't know which they were getting, and they were swapped. And what we found was in this trial, 151 completed the trial, 114 completed all treatment periods, and 4 out of 5 took the tablet daily or most days. And there was no difference in the number or severity of muscle symptoms between statin or placebo. So this is important in primary care because we can tell patients statins rarely cause muscle symptoms, and we can re-challenge the patient, and we can use it, and we can go down the statin tolerance pathway that's been highlighted today. So what about secondary prevention, the benefits? So numbers needed to treat, 12 to 34 over 5 years to prevent one event. Primary prevention, CVD risk at 10%, numbers need to treat 67 for 5 years to prevent 1 event. Disease regression, we've got data showing that you can get plaque volume reduction, particularly with high-dose rosuvastatin, but we haven't seen that equate to any major adverse cardiovascular event outcome reduction yet. Professor Fisher might have some comments on that. So, but patients ask about that. If I take a statin, will it clear my arteries, doctor? And it's, well, it may not clear the arteries, it will certainly stabilize the arteries, and it will lower your risk. So in summary, statins are the cornerstone therapy for treatment for patients with dyslipidemia. We need to remember concordance. The biggest benefit is seen when it's used along lifestyle. And that's really, really important. Patients come to clinic and say, oh, I had a sudden heart attack. My answer to that is it was never sudden. That heart attack took many years in the making. What's going to be different now going forward, and how can we help you achieve your health goals? And we've heard now about new emerging non-statin therapies which are available. And so should we care about targets? Well, I think we should care enough to try and hit the targets, but not care too much if the patient doesn't want to play. And it's all about shared decision-making, supporting. And I think the more support tools we can have, and I'm really interested to know and learn more about Deontics, that how we can support in primary care for a decision support tool, I think we can really ultimately improve the long-term health of our patients. And I'll just finish with the great pathway that's there to support us.